This is Jim Varker for the AAMS Critical Care Transport Academy, Module 9, Assignment 22, Neurology video. We're going to do a case review, discuss a patient that I had, and what was important was to ensure proper sedation of our intubated patients. So this was a 32-year-old female. She went into a local community hospital, 52 kilograms, prior history of bipolar disorder and anxiety. She was brought to the emergency room with altered mental status after an intentional overdose of Wellbutrin and Lamictal. She had slurred speech in the ER. She was observed to have witnessed tonic-clonic seizures, which required them to intubate her. When we arrived, the diagnosis was status epilepticus after an intentional drug overdose, and she needed transport to our specialty neuro center for further care and assessment. The initial assessment of the patient, she was intubated successfully with equal breath sounds bilaterally. Her vitals were stable. She was fine. Intervent settings were normal for this patient. Unfortunately, when we got to the bedside, the patient was sitting up in the bed. She was agitated and wrist restraints, trying to pull her tube. Prior to our arrival, they had given her a gram of Keppra and started her on a Diprovan infusion. She's also given activated charcoal via a nasogastric tube. While we were there, so my partner arrived. I was the sole provider with a sole EMT. Our flight crew was down due to weather. They sent up our flight crew as a second provider. My partner and I discussed the case en route. He was coming at a different time. But on our arrival, my arrival, I went in to prepare the patient, start the paperwork, get the chart, and get the equipment, do an assessment. And my partner arrived a few minutes after me. So while we're at the bedside, one of the nurses gave a bolus of Diprovan, and that lasted about 10 minutes, and her behavior returned with her sitting up and quite anxious and agitated. We asked the doctor for some more medication for sedation. We advocated for some fentanyl for this young lady. The doctor gave her 50 milligrams of fentanyl, which after a few minutes was ineffective. So why do we need to properly sedate these intubated patients? So a lot of our neurological patients are going to be intubated. We need to make sure they're also properly sedated. We want to reduce pain and anxiety. The increased pain and anxiety leads to increased oxygen consumption. Stress responses can make setting up a vent and getting the vent uncomfortable for the patient. We want to reduce the stress and impacts. Patients that have been admitted for a long time to the ICU can actually have depression and develop post-traumatic stress. We want to make sure that whatever sedation that we're giving to the patient is appropriate for that patient. And if we give too much, it can cause some problems. Proper sedation can decrease the length of the ICU admission and also decrease the cost associated with patient care. So one of the recommendations is to use the Richmond Agitation Scale for sedation. So the Richmond Agitation and Sedation Scale score is a targeted therapy. We want to make sure we have a desired sedation. We need to have an endpoint so that we know we're giving the correct dosages. So for most patients, we want the RASS score between 0 and -2. 0 is the patient is alert and calm, and -2 means they awaken to voice or eyes are open, but then they'll usually go right back to sleep. That's the recommended range. So we use this score to measure the severity of the agitation and sedation and target our therapy between 0 and 2. So common medications for sedation for transport includes midazolam or Versed, Diprovan or propofol, etomidate. We can use opioids for both analgesia and for sedation. Fentanyl is usually the preferred one, and also ketamine. Formularies and medications may vary by the system that you work for and the region that you're working in. So Versed or midlazepam is one of the medications that we use quite often. It works on the GABA sites. So GABA reduces postsynaptic neural excitability. It's a chief inhibitory response receptor for the central nervous system. It reduces neural excitability by inhibiting nerve transmissions. This is really good medication for amnesia and for reducing anxiety. Unfortunately, it doesn't provide any analgesia. Your dose is going to be varied. The duration lasts about 30 minutes. May cause respiratory depression, and it can also cause hypotension, so we need to be careful. And we give it, and it does last. It has also a longer onset. It takes a few minutes to work. Propofol is a common medication that's used. It works on GABA as a CNS depressant. One of the things is it's really good for seizure management, which was probably why they were using it for this patient. It's got a really quick onset. The duration is quick. It lasts about 10 minutes, although that's dose dependent. Unfortunately, it can cause cardiovascular suppression and also hypotension. And also it does not provide any pain management either. So we need to make sure we're considering pain management. Etomidate works on our GABA system. It's got a very quick onset, although it's got a very short duration of lasting. It doesn't have a lot of cardiovascular effects, so it doesn't usually cause any hypotension. We need to use it in caution with patients that have adrenal suppression and patients that are in a septic state. And again, it doesn't provide any analgesia. Fentanyl is a synthetic opioid. It's got a rapid onset with a short duration though. It does have analgesic and sedative effects, and that's why we really like it. Usual doses is 1 to 3 mics per kilogram. We can also start in an infusion of 5 to 1.5 mics per kilo per hour. And what we like about fentanyl, it has less cardiovascular effects. It may not cause as much hypotension. Ketamine is also a great medication for sedation for these patients. It works as an NMDA agonist, which decreases GABA. It works as an on the opioid receptors, and it also augments the use of opioids. So this in conjunction with fentanyl is a really good choice. There's different dosages for it, and the dosages can change or vary depending upon your region and your service that you're working for. So it can also be given IM, intranasally, and IV to sedate the patient. Usually it's the respiratory drive is maintained. There's been some discussion that it can increase blood pressure, and there's been some caution in our central nervous system patients, but that's been disproved. So that's not common. It's got a quick onset and it lasts about 15 to 30 minutes. So how would we do to properly manage this patient? I went to the doctor and asked him if we could get some sedation, and the doctor pushed back because I was in my uniform. And my partner went over in his flight crew suit, and they had a discussion, and immediately he came back and decided they were going to give this patient Versed. They gave 2 milligrams, which worked pretty well, and then we hung a infusion at 2 milligrams an hour for transport. The patient quickly settled down. The transport was uneventful. We transferred it to the specialty neuro ICU at our hub hospital. She spent 2 days there, and then she was extubated. No further seizure activity was noted, and she was admitted to the inpatient psych unit for evaluation there. So pearls of wisdom for sedated patients. We want to make sure that we're providing adequate analgesia or pain management. Tubes, an ET tube, a big tasket tube is hard, it's painful, and a G tube is hard, it's painful. we want to make sure that our patients are comfortable and decreasing their pain, decreasing their anxiety. We want to target the therapy to the proper sedation score. We're going to recommend using the RASS score of 0 to 2. We want to make sure that we're monitoring our vitals adequately. And we want to prevent hypoxia and hypotension in all of our neuro patients because that can lead to increased morbidity and mortality. You want to consider using your push dose for short trips if you have a short trip, and consider hanging and infusion for a longer duration transport. References are here, and I have nothing to disclose. And thank you for the opportunities provided to us by the AAMS Critical Care Transport Academy. Thank you.